Is my screen visible?
Yes.
So I present a case. Good evening, everyone. I present a case of intermediate uveitis secondary to the sarcoidosis or rare presentation. So, a 41-year-old female homemaker by occupation came to the eye OPD with the chief complaints of a diminution of vision in both eye, more in the left eye than in the right eye, since past 3 months. She also complained of the floaters in the left eye since 3 months. She was non-diabetic and non-hypertensive. On these are the parameters. Unaided visual acuity in right eye was 6 by 36, improved the 6 by 6 partial, and in left eye it was 6 by 60 and N36 with improvement up to only 6 by 24 with minus 1.5 diopter sphere and minus 2.5 diopter cylinder, and near of the plus one. Entry segment examination, she was a fake kick, and IOP was calculated was 15 in a right eye while 25 in a left eye. Posterior segment examination in right eye was within normal limit with the CDR ratio of 0.7 with NRR healthy. While in left eye, media is hazy. There is an entry vitreous show the vitreous cells. The disc appears to be the normal, but the CDR ratio is 0.7 with the thinning of the superior NRR. And there is a thickening of the macula with the loss of foveal reflex. And there is a presence of the few yellowish white globular structure found in the found in the vitreous and the inferior peripheral retina, which was suggestive of the snowball. So this was the fundus picture of the patient. You can clearly make out these are some snowballs exudation present in the inferior vitreous, while the right eye was clear. This was the OCT of the patient, which was showing the right eye with the normal foveal contour. In left eye, you can clearly examine there is a presence of the cystic space in the fovea, which is suggestive of the cystoid macular edema. So, my probable diagnosis of the patient was left eye intermediate uveitis secondary to the following cause. As we investigate the patient with the CBC investigation with the blood investigation, we sent for CBC, ESR, CRP, FBS, fasting, and HIV, HBS, HG with other investigation like trypanosome hemagglutination test, Montux test, serum AC enzyme, chest X-ray, and HRCT chest. And treatment she was started with on topical steroid in a left eye. With the follow-up of the reports, she came and we see the CRP value was raised to the 8.1, which was normal 0.0 to 5, and serum AC enzyme raised to the 69.10 of the level. And HRCT of the lung reveals there is a patchy ground glass opacity in a left lower lobe, while the atelectic band noted in a left lower lobe, tiny pulmonary cyst noted in a right upper lobe, and a few mediastinal lymph node enlargement. So the symptoms are not resolved with the topical steroids. So she was advised for the intravitreal triamcinolone in the left eye. Post IVTA 1 week when she came, the visual acuity in right eye was same, but in left eye we can see the 6 by 36 unaided visual acuity, which was improved the 6 by 9. And entry segment was phakic, but the IOP you can see clearly spike in the left eye IOP, which was 64 mm of Hg. Posterior segment, the media was clear, and entry segment show the few vitreal cells, and you can see the resolution of edema, and the snowballs are also resolving. So patient then started on a Dimox 250 mg BD for 5 days with the syrup Kesol. Along with it, the topical AGM also added with the Brimocom 0.5 mg BD and Dorzox 2% BD in the left eye. After 1 month, when she came, the visual acuity was clearly improved in left eye, and also right eye was also normal, and IOP was reduced to the 28, while media was clear, and CDR was 0.7, and the resolution of the edema and snowballs also resolved. So you can see the clear fundus picture of the patient, which was snowball all resolved, and the edema also gone. So this is the obesity of the patient, which show the resolution of the edema. Thank you.
Show me the first fundus photograph.
Yes, please.
Can you enlarge it?
Yes, sir.
See the right eye. I don't think there is a zero point 0.7 cupping in the right eye.
Okay, sir.
What do you think, first of all, about the cupping
The
in both eyes?
both eyes it's appear to the sir zero point 0.6 to zero point 0.7 cupping, but which was fundus picture is not so much clear in right eye that suggests of the zero point 0.7 cupping.
Point?
0.7 cupping is not seen in the right eye actually.
Okay. And is she diagnosed glaucomatous cupping outside or somewhere else
No,
before
sir.
starting?
She was not shown to any ophthalmologist. So she was not diagnosed with the glaucoma in any hospital.
Or she was using any steroids before coming to you?
No, sir. She was not using any steroids.
So usually I in intermediate uveitis there is no, I don't think even the left eye there is a zero point 0.7 cupping.
Hmm.
It's around zero point 0.4, zero point 0.3, zero point 0.4. But why there is a rise in IOP in the left eye?
Because of giving triamcinolone and acetonide. So
No,
that
but the in first setting only, no, in the first visit only,
yes,
you
first
show the
visit.
IOP is 24.
Yes, sir. So
So what is the reason behind it? Why there is a rise in IOP in the left eye prior to treatment, even if she is not using any steroids? But I don't think there is a cupping in this case.
mhm, yes, sir.
Have you done AT or not?
Yes, sir. That eye care was done for the patient, and
Okay.
patient was seen to the glaucoma consultant. They also said there is a point 0.1 cupping and NRR was superior rim was thinning.
Okay. So, what are the differential diagnosis for the floaters, and what are the main symptoms of intermediate uveitis?
So, there is a painless blurring of vision associated with the floaters. These are the main complaint with the patient presented with the no entry segment involvement or a minimal entry segment involvement, like in redness, watering, photophobia. The main symptoms that painless loss of blurring of vision, and second complaint is the floaters.
Okay. So, Manisha, what are the symptoms of intermediate uveitis?
Sir, a patient can have redness and photophobia, but usually they don't have much of anterior segment inflammation, and patient can also have diminution of vision, which can be secondary to macular edema, cystoid macular edema.
So, what are the different causes for decrease in vision in case of intermediate uveitis?
Sir,
Children
one
clearly?
is cystoid macular edema.
Yes.
And then if we have grade 5 of vitreous haze, then also patient can have, and vitreous hemorrhage also. And if
Okay.
there are any peripheral tractions,
There is no
no, no,
reasons for a decrease in vision. Peripheral tractions.
won't cause a decrease in.
Uh,
Uh, so
what are
cystoid
the other
macular
causes?
edema, vitreous haze, and then vitreous hemorrhage. What about
Yes.
that?
And what about cataract?
Yes, if patient have cataract, then they can.
Why intermediate uveitis patients have a cataract?
Because the
Sir,
anterior hyaluronic
because of the inflammation or because of steroid treatment, sir.
Yes, good. Because of the inflammation, chronic, usually cases of a chronic intermediate uveitis have a posterior subcapsular cataract as well as because of the chronic use of steroids. Other than cataract, yes, Shifa?
Glaucoma can also be, sir,
Yes, because
prolonged inflammation.
yes,
And a neovascularization also, sir, in few patients we can see.
yes. So, Tulika, what are the signs of intermediate uveitis?
Sir, raised intraocular pressure, KPs.
The yes, KPs and all are even present in the anterior uveitis also. But what are the typical signs of, or what are the typical triad of intermediate uveitis?
Sir, floaters and blurred vision,
I'm asking
paininess,
signs.
signs. Uh,
Yes, Alind?
Snowball
Sir,
banking
vitreous.
and vitreous cells.
Yes, vitritis, snow ball, snow banking. These are the main signs of intermediate uveitis. Shishir is there?
Yes, sir.
Yes, is which type of intermediate uveitis are present with the pain?
Um,
What causes of intermediate uveitis can cause, or what are the causes for pain in intermediate uveitis?
Sir, like inflammatory conditions, which to begin with, there might be intermediate uveitis like leakage and all. They can have pain, sir. To begin with, later it will involve everything. So later it will be panuveitis.
Yes, but
And
the acute anterior uveitis with intermediate uveitis can have a pain, or acute retinal necrosis, जो ARN associated with intermediate uveitis can also have a pain. So these are the two
sir, sir. Okay.
main causes for the pain. Okay.
Yes, sir.
Move to the next slide, Alin.
Yes, sir. This was the OCT of the patient.
Okay. So, what are the investigation you are ocular investigation you are looking for, or what is the purpose of a FFA in the intermediate uveitis patient?
So to look for any vascular sheathing or to look for any
No,
neovascularization, to look for
no.
any disc edema changes, to look for the CNP areas.
Shishir, what are the indications for FFA in intermediate uveitis? What is the
Sir,
use of?
mainly now FFA we do to look at the level of leakage, whether the
Yes.
question the vessel involved is in the choroidal plane or it is in the retinal plane. So to better differentiate that, FFA is useful, sir.
Sometimes the retina picture doesn't give actual information about the inflammation. So by the doing FFA, actual leakage of or actual degree of inflammation will understand. Okay, and in the
Hmm.
future also to look for the treatment and how is the response. We also do a FFA. The main reason, and also sometimes the cystoid macular edema will not appear on the OCT, but it will appear first on FFA or the thickness scan. Okay, so thickness scan of a retina and FF is more sensitive to the CME than OCT. OCT will it will appear later on the OCT. Okay,
Sir, thickness scan means in the
the
OCT that
OCT
6 mm
OCT
raster.
no, yes, in the OCT play you can see the thickness scan. It will appear a red on before
Hmm.
before appearance of the CME also.
Yes, sir.
Okay, so it's better to look at in these cases look on the thickness scan also. Okay. uh,
And if like choroidal leakage and all, it will appear in the early phase only, no, before
yes, but
even
yeah,
beginning.
but usually intermediate uveitis choroidal leakage and all, it's very in severe stages, but you have to just vascular leakages and to monitor the sometimes after a treatment of a few months you can see the fundus is very clear, there is no snowball snow banking, but when you do a FFA there is a might be a leakage, or you don't want to stop your steroids or IMT before doing a FFA, so it's always better to do a FFA at the end of a treatment to see for the leakages. If there is a leakage, then continue your treatment. If there is no
Treatment.
leakage or no hot disk, then you can stop or taper your medication.
Okay. Uh,
Okay. Okay. Now, Rahul, you can
Yes, sir.
start your presentation.
Stop my screen.
We'll ask more questions and have a discussion in Rahul's presentation.
Yes. Am I audible?
Yes, yes.
So good evening all. Today's topic is intermediate uveitis. Intermediate uveitis is a chronic intraocular inflammation that predominantly involves vitreous peripheral retina and pars plana with minimal anterior chamber and posterior pole involvement. And the idiopathic form of intermediate uveitis associated with snow banking and snowball is termed as pars planitis. In this first picture, we can see the snowballs, which are the clumps of inflammatory aggregates present in the inferior vitreous. And in the second picture, we can see the inflammatory plaques on the pars plana region, which is termed as snow banking. Coming to etiology, it can be divided into infectious cause and non-infectious causes. Infectious, first we have to rule out the infectious cause before starting the patient on systemic steroid or immunosuppressant drugs. The infectious causes are tuberculosis, syphilis, Lyme's disease, and can sometimes toxoplasmosis can also present as intermediate uveitis. And the infectious causes are idiopathic is the most common. Around 60 to 70% of the intermediate uveitis cases are idiopathic. Other causes are sarcoidosis, multiple sclerosis, and inflammatory bowel disease. So the features of infectious causes are tuberculosis, which usually presents as granulomatous uveitis with posterior synechiae, vitreous snowball, and peripheral vasculitis. It can be investigated with the help of Montus test or chest X-ray or HRCT, and even the sputum PCR can be done. Syphilis can mimic any type of uveitis with retinal vasculitis, placoid choroidoretinitis, or papillitis. It can be diagnosed with VDRL and TPHA test. Lyme's disease is usually present in endemic areas which are prone to tick bites and can be diagnosed with Lyme ELISA. Toxoplasmosis presents as focal necrotizing chorioretinitis with adjacent to old scar with overlying vitritis. It is usually diagnosed with a clinical examination. Sometimes Toxoplasma IgG IgM serology can also be done. Then coming to non-infectious causes, idiopathic should be a diagnosis of exclusion after ruling out other systemic causes. Sarcoidosis usually presents as granulomatous anterior uveitis with vitreous snowball and periphlebitis, which can be diagnosed with the help of HRCT or chest X-ray and also serum ACE levels. This first picture is the X-ray of a patient with sarcoidosis, which shows bilateral hilar lymphadenopathy. Multiple sclerosis, it can present with intermediate uveitis with periphlebitis, optic neuritis, or recurrent cystoid macular edema. And other neurological symptoms can be like paresthesia, like tingling, numbness, sensations in the limbs. It can be diagnosed with the help of MRI brain and spine. In this picture, we can see the periventricular white matter lesions, which are seen in the case of multiple sclerosis. So coming to clinical features, symptoms, patient usually presents with floaters due to vitreous cells and clumps. Blurred vision can be either due to vitritis and mainly due to cystoid macular edema. Other symptoms can be mild redness or pain, and it is often presents as bilateral but can be asymmetric. Clinical features, signs, anterior chamber shows mild AC cells and flares. Vitreous, there can be vitreous cells and haze, snowballs, and snow banking. Other fundus findings can be peripheral vasculitis, cystoid macular edema, optic disc edema, and neovascularization. So coming to diagnosis and workup, thorough clinical examination should be done. Careful slit lamp examination should be done for anterior chamber activity. Indirect ophthalmoscopy with scleral depression has to be done to look for pars plana snow banking and peripheral vasculitis. Ocular imaging like OCT should be done to detect cystoid macular edema, epiretinal membrane, fundus fluorescein angiography to detect the retinal vasculitis, vascular leakages, and cystoid macular edema. In case of dense vitritis and hazy media, B-scan ultrasonography can also be done. And coming to systemic evaluation, CBC, ESR, RBS, RFT, LFT has to be done in all patients before starting treatment. That is either steroid or immunomodulatory therapy. For tuberculosis, chest X-ray or HRCT, Montus test can be done. For sarcoidosis, again chest X-ray or HRCT can be done. Serum AC level can also be done, but it is non-specific test. For multiple sclerosis, brain MRI or spine can be done. VDRL or TPHA can be done for the syphilis. And for Lyme's disease, Lyme ELISA is done. Treatment goals should be to suppress the inflammation, to prevent the complication, and preserve the vision. Treatment are usually corticosteroids. For unilateral cases, periocular subtenon triamcinolone injection can be given. For severe or bilateral cases, oral steroid should be started. For patients with systemic association like multiple sclerosis, sarcoidosis, immunomodulatory therapy should be started with either methotrexate, azathioprine, or mycophenolate can be used. But like local therapies like intravitreal steroid implants like Ozodres can be done. It provides sustained release of corticosteroid to control the cystoid macular edema and vitreous inflammation. Intravitreal injections can be used in retinal neovascularization to prevent the hemorrhage. And for systemic disease, antitubercular therapy should be started for cases with tuberculosis. And immunomodulatory therapy should be started for cases with multiple sclerosis, sarcoidosis, or inflammatory bowel disease in collaboration with the rheumatologist. Coming to surgical intervention, cataract extraction can be done, but it should be done after at least a 3-month period of inactivity. Parsvena vitrectomy is indicated for cases of non-resolving vitreous opacities, recurrent CME, or for diagnostic purpose. Complications of intermediate uveitis are cystoid macular edema, which is the most common cause of vision loss. And cataract, it is usually posterior subcapsular type. It can develop either due to steroid used in treatment or due to chronic inflammation. And then the other complication is glaucoma. It can also be due to steroid treatment or due to trabecular meshwork damage or secondary angle closure. Then there can be development of the epiretinal membrane due to proliferation of the glial cells over the macula, retinal neovascularization, and this neovascularization can either lead to vitreous hemorrhage. And sometimes there can be even tractional retinal detachment. Thank you.
Nice. So Vaishali is there.
Yes, sir.
So Vaishali, tell me how you approach the case of an intermediate uveitis. Suppose you are sitting in a OPD. There is a 40-year-old male came with the complaint of a decrease in vision and floaters. So how you proceed this patient, and you are doing an examination. You think it is an intermediate uveitis. So how will you proceed?
Uh, so, like after slit lamp examination, visual acuity is all done, and now I have diagnosed with intermediate uveitis. And now you're asking what further management will
Hmm.
be doing? Okay.
It
So,
is a
will
unilateral.
unilateral.
Yes. What are the ocular tests you are going to do? What are the systemic investigations you are going to do? How you will follow up this patient and how will
So,
treat the patient?
ocular ocular examination will advise for OCT to rule out any edema,
Hmm.
and if then systemic investigation, we advise CBC, ESR, CRP. If we To rule out TB, we advise Montauk's test. Then to rule out sarcoidosis, we advise serum AC level. For syphilis, VDRL, and
So
also for
before starting, suppose you want to start oral steroids, okay, not
okay,
a topic or not a periocular. You want to
okay.
start oral steroids. So how will you proceed for the oral steroids? What you want to rule out first?
Sir, infective etiology.
What are the infective etiology?
So tuberculosis, syphilis, Lyme's disease. Lyme's disease is not common in India, so.
Hmm.
Mm,
And how will you start the Oral steroids. What other test will
Sir,
require
oral
for oral
steroid
steroids?
1 milligram per. Yes, sir.
What other test will require for the oral steroids before starting?
Sir, will also rule out toxoplasma.
Okay. How will you rule out toxoplasma?
Sir, IgM, IgG level.
Okay. Yes, Shishir, you want to do IgG, IgM in every patient?
No, sir. Actually, toxoplasma diagnosis is mostly clinically only. Uh, More often than not, you will see the scar, old scar or any fresh scar, that headlight in the fog appearance. Most often, you'll see. Then also, if we are not seeing, also if there is a strong suspicion of that, then only we will go for IgG, or else we will start anti-toxoplasma treatment. And if it is again not resolving and all, then to confirm whether it is there or not, we will do, sir. Generally, we don't do here in every patient.
Yes, toxo is very rare in toxo is very common, but toxo causing intermediate uveitis is quite rare. Yes, there are some case reports that toxo causing intermediate uveitis are present, but as such, toxoplasmosis is very not that much common to cause intermediate uveitis. Okay, then again, next, yes, Vaishali,
Yes, sir.
how will proceed? You rule out toxoplasma.
Sir, will start on local steroid therapy and systemic
No, but
steroid
you want to
therapy.
start oral steroids.
Sir, will start 1 milligram per kg per day. Will start.
Okay. How will monitor the oral steroids response? Basically, I am asking you if you want to start oral steroids any patients of your uveitis, intermediate uveitis, anterior uveitis. How will you monitor that patient, or how will assess
Sir, will
the
ask to
steroid
follow up
response,
every week for 1 month,
assess the
every
side
week.
effects of the steroids? I am asking all that. Hello.
Yes, sir.
Huh. Yes, Aline.
We check for the patient's IOP raised, or we check every weekly. Every weekly we check the patient's IOP. We check for any decrease in the inflammation, and if it is reducing the if it is inflammation starts reducing, then we can taper the steroids.
Okay. Uh, yes. Uh, Vaishali, what are the periocular steroids?
Uh, Periocular,
Yes, periocular,
sir,
intraocular and
triamcinolone acetonide injection we can give
hmm.
40 mg in 0.5 ml.
Sorry,
Triamcinolone acetonide injection we can give, sir, subcutaneous 40 mg in 0.5 ml.
40 mg.
In 0.5 ml.
Okay. Then what
Vaishal, it is
about
more actually. Periocular, we can give more, not zero point 0.5 will
yes?
be too less.
Okay. Then, sir, fluocinolone acetonide also we can give 0.19 milligrams.
What about the intraocular?
Intraocular, sir, Ozurdex implant, which is a dexamethasone implant we can give. So it decreases the need for multiple injections.
Yes. So what are the Rahul? What are the side effects of periocular steroids?
It can lead to glaucoma.
Yes.
Mm.
Uh, there are more than a glaucoma. Yes,
Cataract.
Dr. Akshay.
So cataract.
Okay, but all steroids, even topical steroids, can cause a glaucoma, cataract. But what are the typical side effects of a periocular? What are the main side effects that related to the periocular rather than in general steroids? Typical for the
Yes,
periocular.
PSPR,
You tell the patients that
Scarring uh, of sight.
PSPR,
Delayed corneal healing, sir. It-
we are talking
Or
not
more
Scarring of
prone to
scarring
infection.
of injection site.
okay. Scarring of injection site.
Infections are prone to infection or
sir,
Scleral.
exophthalmos.
Uh, that is actually
few
not.
cases.
Yes, there is a lot of space, so we are not injecting that much. So they are not actually causing the. No.
Ptosis
Sir,
are
one
related in
thing
very
is
rare cases. Ptosis.
we have to inject that in posterior subtenon space. So accidentally we can perforate the globe also.
Yes, this is one of the most common side effect, perforation. Rather than perforation, there is conjunctival necrosis. If you inject a lot in the conjunctiva, there might be a conjunctival necrosis. Repeated injection can cause lacrimal gland atrophy.
Ptosis also, sir.
Yes, repeated injection can cause
Ptosis.
ptosis. Yes. So, for one question for Shishir, suppose you are seeing a patient with there is similarly floaters, decrease in vision, but you cannot, like intermediate uveitis, you can see a snowball, snow banking, but there is so much haze, so you cannot see the fundus. So, what are your differential diagnosis in such patients, and how will proceed that patient with that patients? Where you are not able to see, there is so much vitritis that you are not able to see any lesions, disc, or there is only vitritis. So how will proceed such cases? So what are the differential diagnosis for such cases?
Sir, one of the again common cause will be can be toxoplasma, sir, wherein we get a lot of
Yes,
vitritis.
good.
So in those cases, B scan will be useful, sir, to
Okay,
rule out the retina status, whether is there any retinal detachment or
but
and even
I
uh,
don't think toxo and retinal detachment will go with hand in hand. So
sir,
one
it is
differential is a
rare.
toxoplasma other than toxoplasma.
Uh, Other than toxoplasma, even cases of like retinal necrosis and all can have severe vitritis.
Yes, good. Other than
Mm,
retinal ARN. So how you suppose there is a patient, you say you are similar patient, you have to differentiate toxoplasma and the ARN. So how will you clinically differentiate between the toxoplasma and ARN? Where there is a no fundus picture available or there is so much vitritis. So how will
uh,
clinically look for the other clues?
Sir, in ARN, we even get anterior chamber inflammation, which is quite common.
So
Like you'll get
as toxo.
epis and thing.
Okay, but there is so much vitritis, so there might be a spillover in the anterior chamber in both cases.
PET
Yes.
exposure. History.
Sorry,
History of PET exposure.
history of. Okay,
Uh,
Cat
but
PET.
exposure.
yeah, there might be a exposure 10 years back, 15 years back.
Hmm.
Anyone else? Rahul, Alin?
ARN can present with pain, but toxo.
Yes, very good. ARN, usually ARN is associated. ARN is the only retinitis where there is a pain. So ARN patient have a pain usually.
Hmm.
So
Hmm.
and onset of symptom onset and signs is more acute than the toxoplasma. Okay.
Hmm.
Is next differential diagnosis Shishir? ARN rather than ARN and toxoplasma. What else?
Again, like sarcoidosis is also more common, sir, leading to intense vitritis.
Okay, but
Uh,
sarcoidosis is not that much intense vitritis.
uh, and infective causes tuberculosis. And,
Even again,
uh,
tuberculosis and all don't present at such much. One of the cause is endogenous endophthalmitis.
hmm.
Okay, even endogenous endophthalmitis also present like extensive posterior pole reaction where you cannot. So at that point you can ask for the any intravitreal injections and any IV drip or some sort of drug abuser and all things. Okay.
Hmm. But they have that exudates, like typical yellowish exudates and all in.
Yes. But that typically present even in toxo also. That exudates inferiorly or the posterior pole exudates.
Hmm.
So, uh, other than Monica,
Yes, sir.
what is the difference between snowball and snow banking?
So snowballs are the focal exudate in the inferior part of the peripheral retina, while the
Hmm.
snow banking are the plaque. The coagulation of the all the snow balls will lead to the plaque appearance, and inferior there will be the snow banking.
So, is there any uh, difference between how to treat snowballs or snow banking? Is there any difference treating these kind of patients, or is there any clinical significance of snowballs versus snow banking?
Sir,
What is the most
there is
common site of
presence
snow
of snow,
banking and snowballs?
yes, sir. Uh, Sir, if there is a there is presence of snow banking, then the severity of inflammation is very high,
Hmm.
and we should like our treatment should be aggressive for the present in the presence of the snow banking.
Hmm.
Sir, this snow banking and all, they are usually formed in pars plana region. So over the period of time, they can form a membrane and contract and all. So uh, it can lead to the this thing, some kind of UL effusion and all. IOP will be low and all. These membranes can contract.
Yeah, this is not called UV effusion. This is called blunting of the ciliary processes over a period
Uh,
of time. Not snow
uh,
banking, but usually a
okay.
chronicity of the intermediate uveitis. So that
Uh,
will eventually cause the cataract, phthisis, and all things.
yes.
Okay. So, Monica, what is the difference between pars planitis and intermediate uveitis?
Sir, in pars planitis, if there is association with the snow banking and the snowballs, then we can call it as a pars planitis, and the idiopathic with no absolute cause.
Okay. So, Alind, what is the stepwise approach for the treatment of intermediate uveitis?
So according to the Kaplan, we must start first with the steroid, only oral steroid. Then we can move to the periocular steroid
No,
injections,
first is not, I think, not the oral steroid. First is,
periocular steroids.
yes.
Then we starts with the oral steroids.
Hmm.
Then we move to the immunosuppressive therapy. If it's not, then we can go to the surgical approach like paraspinal vitrectomy.
Okay. So, what are the indications for to start the immunotherapy, modulator therapy, IMT?
If we give the steroid have lot much, if the periocular steroid are we giving, it's not CME can reoccur. If there is a reoccurrence of the CME or a reoccurrence of vitritis, then we can move to the immunosuppressive therapy.
No, but how you directly move periocular to IMT?
Uh, no, if from the periocular we can go to the oral steroid. If still there is a not there is a recurrence of a CME or recurrence of the symptoms, then we can move to the immunosuppressive therapy.
Shishir, what are the when you will start IMT in a intermediate uveitis?
Sir, first now intermediate uveitis, we have to look for laterality, whether it is unilateral or bilateral. So
Yes.
if it is bilateral, then directly we will start oral steroids, and
Yes.
uh, and we will meanwhile we have to first make the diagnosis whether it is like infective or non-infective. If it is a infective, definitely we have to add antibiotics or any whatever infection it is there. Along with that only we have to start the steroids.
Mhm.
And if it is a non-infective case, if it is not resolving or if it is needing like very long-term treatment, then generally after 4 to 6 weeks of oral steroids, we will taper and we will put the patient on immunomodulatory therapy, since the side effects of steroids are so much. So generally 4 to 6 weeks later, even if the thing intermediate uveitis is very active, then we will, along with the oral steroids, low dose oral steroids, we will start on immunomodulatory therapy. So if it is unilateral, then at first we can give periocular steroids only to begin with, and then later go for oral steroids to again minimize the systemic side effects.
Oh, okay. Okay. Then any more questions? Is sir is there? Saurabh sir? I think sir is not there, no?
Yes, sir.
Okay. Any questions?
Sir, I have
Okay
a
then.
question.
Ah, yes.
So if the patient comes with only just vitreous hemorrhage,
Mhm.
with the hand motions vision, and
Mhm.
if that might be those due to the secondary to any intermediate uveitis, then sir, what would be the plan? We should wait, or should we give anti-VEGF for
But
steroids?
it's not like that. It's if you, this is your patient, you know the patient from the beginning.
Yes.
It is intermediate uveitis, you treated it and then it will come with the vitreous hemorrhage. That means it has a more of snow banking and all that, that leads to the neovascularization that will bleed. But as such, intermediate uveitis will not bleed. The neovascularization over a period of a time that develops, it will require anti-VEGF. Yes, definitely anti-VEGF will help. If not resolved with the anti-VEGF, you will go with the surgery.
Okay, sir.
But as patient came to you with the vitreous hemorrhage, you cannot say that it's because of the intermediate uveitis or because of the other reason like RVO or this. But patient is with you and that will develop eventually. But I think before developing that, you should do a laser when there is no activity and all. Peripheral PRP is better to do beforehand only. Okay.
Yes, sir.
Okay. Any questions? Okay, then we'll conclude. Yes, Manisha?
Yes, sir. Sir, I have a question.
Yes, yes.
Uh, when will we say that there's failure of systemic steroid therapy? Like, how long should we wait?
No, it's not like a failure of the systemic steroid. There is actually a recurrence of inflammation, or there is some underlying cause, like uh, we are missing the what MS, or like there is a child have a repeated attacks of intermediate. There is not a failure actually. If you are not treating the patient adequately, then and then only the patient will fail. So before stopping the, or before the tapering steroids, or before the stopping steroid, you must do a FFA. If the FFA shows the leakage, then don't stop the treatment. If 4 or 6 weeks there, or you have a patient there, you can you give a full course of steroids, and then again there is a persistent inflammation or recurrence of the inflammation, then you can start with the full dose of a steroid along with the IMT. Okay, so it's not like that ki you give a 4 or 6 week of steroid, then you stop and then you start the IMT. It's not like that. You, if you fail, your treatment failed, that means you start again the 1 gram per kg dose. Along with that, you start the IMT, immunomodulators, and then you continue the treatment. And by just looking uh, the fundus, you cannot say there is inflammation or not. Even if there is a hot disk, or there is a peripheral leakages, or some point of leakages, also need a treatment aggressively.
Okay, sir.
Okay.
Yes, sir.
Yes. Okay. Thank you.
Thank you,
Nice
sir.
class.
Thank you, sir.
Thank you.
Thank you, sir.
Okay.